I will be presenting on an article related to my field of study, paramedic. The article is titled Effect of Pre-Hospital Airway Management on Cardiac Arrest Outcomes: Why Our Airway Choices Matter, by Jason McMullen, MD, and Justin Benoit, MD. Why our airway choices matter. Endotracheal intubation has been a defining skill of a paramedic. Unlike emergency departments with ample time, space, lighting, and resources, emergency providers are often forced to act immediately and in a less than ideal environment. Out-of-hospital cardiac arrest is a classic case of forced action without time to prepare, and cardiac arrest victims are the most frequent EMS intubations. Recent conversations regarding cardiac arrest have focused on the importance of compression rate and depth, adequate recoil, perishock pauses, CPR density, pit crew modeling, mechanical compression devices, and termination of resuscitation rules. The American Heart Association even restructured the resuscitation alphabet, ABCs, to put C, which stands for compressions, before A, which stands for opening the airway, all in the best interest of the patient. While paying attention to compressions is of prime importance, the criticality of airway management still remains. So here are the old ABCs of CPR, where opening the airway of the patient came before checking for breathing and C, compressions. And here are the ABCs of CPR that are used today, where chest compressions come before opening the airway and checking for breathing of the patient. By the numbers, there are approximately 300,000 cases of out-of-hospital cardiac arrest in the United States every year. 80% will get an advanced pre-hospital airway, 30% will be left at the scene after termination or resuscitation, 33% will get return of posthumous circulation (RLC), 25% will get admitted to the hospital, 10% will survive to hospital discharge, and 6% will be discharged neurologically intact. There are essentially three options to choose from to manage the patient's airway during out-of-hospital cardiac arrest. There is the bag valve mask, the BVM, which is this one right here. There is the supraglottic airway, the SGA, which is also called the combi tube, the laryngeal mask airway, the King airway, and the supraglottic airway laryngopharyngeal tube, which is this one right here. And there is also the endotracheal intubation, which is this one right here. ETI is the most common intervention, but there's growing support for SGAs as first-line airways, particularly to ensure that there are few interruptions and compressions during the early phases of resuscitation. The Resuscitation Outcomes, the Consortium Experience. The Resuscitation Outcomes Consortium, RLC, is a multicity North American research network that has focused on improving out-of-hospital cardiac arrest and trauma care. The RLC pre-hospital resuscitation using an impedance valve and early versus delayed primed study prospectively enrolled about 10,000 subjects and randomized them to early versus late rhythm analysis and real versus sham impedance threshold device. While RLC Prime doesn't directly address the role of pre-hospital airway management, the robust nature of the study allowed investigators to perform a secondary analysis of the data. In the secondary analysis, 8,487 patients who underwent ETI were compared to 1,968 patients who had an SGA placed. Neurologically intact survival to hospital discharge was higher in those with an endotracheal intubation than those with an SGA. After adjusting for many factors such as age, initial rhythm, and bystander CPR, the odds of survival were better for those with an ETI. The odds for RLC and 24-hour survival were also higher for patients with ETI, and results persisted when patients with unsuccessful airway maneuvers were excluded. In this group of patients, there's a small but meaningful difference in outcomes based on how paramedics manage the patient's airway. The resuscitation outcomes the Japanese experience. In the all-Japanese Usain registry, almost 650,000 patients' records from a 6-year period were analyzed and were concluded that bag valve mask ventilation was associated with a 2.6 times greater chance of neurological intact survivors when compared to an ETI or SGA placement. Advanced life support, including ETI and SGA placement, is a relatively new skill. In fact, this analysis only 6% underwent ETI and 57% were managed with BVM alone. This sharply contrasts with common practices in the United States. Additionally, approximately 18% of included cases suffered a traumatic arrest, and these patients are expected to have dismal outcomes regardless of EMS interventions. The analysis observed a low overall neurologically intact survival rate of 2.1, which is approximately 3 times lower than in the US. There have been other factors involved that altered the potential benefits of an airway procedure, even though specific airway management choices were associated with survival. So here are some Japanese paramedics demonstrating CPR compressions on a mannequin. The cardiac arrest registry to enhance survival experience. The cardiac arrest registry to enhance survival cares was created in 2004 as a collaboration between Emory University, the Centers for Disease Control and Prevention, and the American Heart Association. Similar to the Japanese registry, CARES allows insight into the broad practice of cardiac arrest resuscitation and presents an opportunity to explore the relationship between pre-hospital airway management and outcomes in the U.S. Patients who didn't undergo advanced airway placement had better neurologic outcomes than those who received ETI or SGA. So here it shows how many patients survived using these airway management. Association doesn't equal causation. There are unmeasured and unmeasurable factors that influence both the airway decision and the patient's outcome, no matter how hard EMS providers try to control for them, which is why a causal relationship is difficult to determine. A common mistake is interpreting these results and confusing association and causation. Association means that two things are related in some way or are often found together, whereas causation implies a definite cause and effect relationship. Do no harm and do no harm. Treatment priorities are established as soon as the first rescuer reaches a patient in cardiac arrest, and each decision should be done to maximize the chance of neurologically intact survival. Uninterrupted chest compressions are absolutely essential, and rapid treatment of shockable rhythms is arguably the highest of all priorities. So here are paramedics inside an ambulance working on a patient, trying to keep his circulation of his blood and his air going with the compressions. Then here are paramedics carrying a patient towards an ambulance. And here is a picture showing compressions. Your choice matters. These 3 studies all show that pre-hospital airway management is significantly associated with neurologic outcomes. EMS providers are recommended to practice BVM, ventilation, and other airway skills. The use of feedback devices help to avoid hyperventilation in patients. Capnography is the best method to prevent this. Capnography is basically the monitoring of the concentration and partial pressure of carbon dioxide in the respiratory gases, trying to give a patient more oxygen to balance the carbon dioxide in the body. Okay. EMS providers must pay attention to their crew's approach to airway management. Even a single successful attempt may harm the patient in the long run if compressions are interrupted or hypoxia time is prolonged. So compressions, the main thing here in airway management are compressions, because that is what keeps the air going in the body, since the patient that is in cardiac arrest cannot breathe on their own. And if compressions or CPR doesn't work, then there is always advanced care, which is sending the patient to the hospital. Here are a couple devices of capnography that provide oxygen to a patient. Here is a face mask where the oxygen goes through the tube, and this mask covers the nose and the mouth of the patient. And here is a nasal cannula that is inserted through the nostrils and provides oxygen to the patient as well. The bottom line, EMS airway management will always be a critical component of cardiac arrest management. No matter which ventilation method is used, EMS providers must monitor the effect and guide their team to provide effective ventilations, just as they guide them for effective compressions. So here again are the ABCs or CAVs of CPR, showing compressions to keep the air going through the body and the blood, and checking for airway, opening the airway of the patient to allow the oxygen in, and checking for breathing. And here are a couple paramedics applying compressions to a patient and giving oxygen to a patient with a bag valve mask. And here are a couple paramedics strapping a patient to take him to the ambulance. And here's the works cited page and all the information from my article.